Ladies and gentlemen, welcome back. We have three plenaries, and we will begin off first. Our own Professor Shinki An, Director of the Yonsei Institute for Global Health, will moderate the session on equitable vaccine accessibility and lessons learned from the COVID-19 pandemic. Professor An, the stage is all yours.
Thank you. Good afternoon, everyone. I'm Shinki An. As I was introduced, I'm the director of Yonsei Institute for Global Health. So for this plenary sessions, we have 5 distinguished panelists today, and I'd like to introduce them to you briefly. Okay, here we have Mr. Mark Buttigieg. He is the Economic Diplomacy Counsellor of the British Embassy. He taught Korean students long time ago, and he came back to UK and he began his civil service, and he came back to Korea as the British Counsellor. And then we have Dr. David Do, the Director of Corporate Strategy and Affairs of AstraZeneca Korea. He led negotiations and supply of COVID-19 vaccines in Korea, and he greatly contributed to the COVAX supply over 75 countries. Thank you for joining us today. And we have Professor Joon Yeom. He is the director of the Center for Global Development of the Yonsei Institute for Global Health. And he's an infectious disease physician and professor at the Department of Internal Medicine at Yonsei University College of Medicine. And here we have Dr. Jerome Kim online. And Dr. Jerome Kim is the Director General of International Vaccine Institute, Seoul, Korea. He is one of the leading researchers and vaccine experts in the world. Now he is in Sweden because IVI opened the new international office in Sweden. Congratulations. And finally, we have Professor Peter J. Hotez, the Dean for the National School of Tropical Medicine at Baylor College of Medicine, and the Professor of the Department of Pediatrics and Molecular Virology and Microbiology. He will present his insight through video. In the last year, when we held GEEF 2021, we had to prepare an online conference because of the COVID-19 pandemic. At that time, we thought that GEEF 2022 would be an on-site conference because we were going to have vaccines against COVID-19 and we could control the epidemic. But we still have a long way to go. And by this time, 62% of world population has received at least 1 dose of COVID-19 vaccine, and more than 10 billion doses have been given globally. On every single day, about 25 million are being administered. Without international collaboration to develop, produce, and distribute COVID-19 vaccines, these numbers cannot be possible. The COVAX, led by WHO and Gavi and CEPI, can be a representative outcome of these multilateral endeavors. However, in spite of this international effort about the equitable distribution of vaccines, vaccination in low and middle-income countries is still very low compared to that of developed countries. For example, only 11% of people in low-income countries have received at least 1 dose. This gap might be considered as a retrograde outcome of this sustainable development goal period or agenda. On the other hand, with the appearance of the Omicron mutant type, the number of infections is staggering. In the case of South Korea, the number of confirmed cases has reached 50,000 per day. It's a huge spread indeed. Experts say that we are in a phase of exponentiality. Vaccination can be said to reduce the disease severity rather than to prevent the infection itself. But various controversies related to vaccination are still going on. So many countries, institutions, and even individual researchers have been thinking about solving this problem. So I hope that this session will be a chance to share lessons learned so far and future development possibilities with international organizations, countries, and researchers. So, in order to share your precious experience and insight, we need to have many times, but because of limitation of times, so we just can give 7 to 8 minutes for your talk. So please understand us. So I'd like to give question to Dr. Kim, Jerome Kim first. So by the way, your local time is 5:30 a.m., early in the morning. Wow. So thank you again for joining us today. So you are the Director General of the IVI and probably one of the busiest people in this COVID-19 era. So IVI is an international organization that deals with the overall vaccine value chain, including research, development, and dissemination of vaccines, and stands at the center in terms of equal distribution of vaccines. So, Dr. Kim, please share with us the role of IVI in these processes and share your opinion on the achievements and future development directions for the equal or equitable distribution of vaccines. Dr. Kim, please.
Thank you, Professor An, and good day to everybody. IVI is the actually first international organization headquartered in South Korea. Our mission is to discover, develop, and deliver safe, effective, and affordable vaccines for global health. And that means that IVI does nearly everything in the vaccine value chain, from establishing the burden of disease or helping countries with the diagnosis of disease so that they are aware of where the disease is and how severe it is, to testing, developing new vaccines in the laboratory, testing them in animals, doing what we call animal challenge studies, so vaccinating animals and challenging them with the pathogen to establish that a vaccine meets a proof of concept of protection against disease or infection, and then doing clinical testing of the vaccine in phases 1, 2, and 3, which I think everyone now is familiar with because of COVID, the stages of human clinical testing, and then helping companies with the approval of vaccines to get them through the regulatory approvals in the country of origin and then with the World Health Organization as well. And then finally, we do effectiveness and health economic studies in order to establish that vaccines are actually doing what we think they're supposed to do in the real world, so generating real world evidence that will inform policy. And then also providing policymakers, so not only people at the Ministry of Finance, for instance, but people at the Ministry of Health, but also people at the Ministry of Finance, with proof that vaccines are reducing disease and are cost effective. And all of these things together constitute what IVI considers its contribution. And actually, we see it very well in COVID, because in February of 2020, it seems such a long time ago now, 2 years, IVI made a decision not to make its own vaccine, but instead to help any company or organization that had a vaccine move that vaccine forward. So we've worked with countries to strengthen diagnostics with support from CETA and the Bill and Melinda Gates Foundation, to strengthen their capacity to do phase 3 trials, which is very important now, and I'll go into that in just a second. We've tested vaccines in animals and done animal challenge studies with some of those vaccines. We're working with companies in human clinical trials to do phase 1, phase 2, and phase 3 testing of those COVID-19 vaccines. And we are now engaged in what we call effectiveness studies, generating real world evidence, not necessarily with the vaccines that we have available in Korea with Moderna, Pfizer, AstraZeneca, but many of the vaccines that are in use throughout the world. So this would include vaccines from China, as well as, in one case, the vaccines from Russia. So IVI, because it can do all these things, is working with companies that have committed 1.2 billion doses to COVAX, the global mechanism for the distribution of vaccine at low or no cost to low and middle income countries around the world. And I think the 194 people at IVI have been very busy over the last 2 years, and everything that we can do, we've tried to do. In fact, one of the other panelists, Dr. Peter Hotez, is a good colleague of mine, and we've talked a lot about their vaccine and how we might be able to spread that vaccine technology to other countries around the world. In terms of where IVI sees future vaccine equity, so we are, during the non-COVID times, IVI is very concerned with what we call unincentivized vaccines. That is, vaccines for conditions, infectious disease conditions, which don't necessarily exist in high-income countries like Korea, in the United States, or in Europe. On diseases like cholera and enteric fever or typhoid, on non-typhoidal salmonella infections, on group A strep infections, diseases that kill hundreds of thousands of people a year, but have no major vaccine manufacturer interested in developing a vaccine. Why? Because when you're developing a vaccine for global health, you're developing a vaccine that can cost $1.50 a dose. And that kind of economic reality isn't one that generates high levels of revenue for these vaccines. And because the problems don't exist in high-income countries, it's very difficult sometimes to encourage companies to get involved in the development of global health vaccines. So our contribution to global health equity is to develop vaccines for diseases of high burden in low and middle income countries, to get those vaccines manufactured by manufacturers who can meet the quality regulations that are necessary for WHO to approve the vaccines and recommend them, then to work with ministries of health and ultimately, I guess, with ministries of finance to implement programs to use those vaccines for impact. Because we know that vaccines are some of the most impactful investments that a government can make. Studies show that in low and middle income countries, for every dollar a country invests in vaccines, they save $16 in healthcare costs, direct healthcare costs, and a total of $44 saved in total costs. That is cost to society, cost to the economy. So vaccines are cost effective with a very high return on investment. And by moving vaccines forward, IVI is able to address the question of equity, address the question of manufacturing. We have ourselves done 8 technology transfers of vaccines to low and middle, to what we call developing country vaccine manufacturers. Many of those vaccines are now pre-qualified, that is approved by WHO, recommended by WHO, and in use throughout the world. Thank you.
Thank you. So, the typical reality of the disease that require vaccination is somewhat different the current experience of COVID-19. So based on your explanation. So we need to think about rather preferable options for the low and middle income countries because they have a different but great disease burden which requires vaccinations.
Yes, that's a great point. And we are facing the reality of what happens when we don't have that. We know that there was going to be a huge human cost in not distributing vaccines equitably. We had projected that human deaths would double back in June of 2020. These are projections from the Gates Foundation. At that point, the number of deaths around the world was 400,000. Now we're approaching 6 million. And as you pointed out, 90% of people in low-income countries have not gotten a single dose of vaccine. And as a consequence, we know that there have been a significant number of infections. You don't see it on the maps. When you look at the maps of the number of cases per day, you don't see a lot of cases per day reported, for instance, in Africa. But we are doing some studies trying to use new vaccines in Africa, and up to 90 to 100% of the people who come in for screening have already been infected. So they show serological or antibody evidence of prior infection. So we know now that the infections were there. Presumably people died, but there was no record because one of the big gaps, other than the vaccine gap, is an equity gap in diagnostics.
Yes, yes.
And then a consequence of that is that we don't know where the variants are. And luckily there are great scientists in South Africa who did some of the sequencing, who showed that the Omicron variant was present there. For 170 full-length sequences done in the month of November 2021 in all of sub-Saharan Africa, there were 170,000 full-length sequences of COVID-19 or SARS-CoV-2 done in Europe. So the diagnostics and sequencing gap is another thing that we have to think about as we think about how and where to deploy vaccines for COVID-19.
Yes, thank you for your opinion and comment. So while I'm listen to Dr. Jerome's comment, so I can realize the importance of pharmaceutical companies. So I'd like to ask Dr. Do, AstraZeneca has been showing leadership in promoting global health recovery and equitable vaccine access by developing a non-profit vaccine. So, for example, AZD 1222. Could you explain further the concept of a non-profit vaccine and share your thoughts on the ways in which AstraZeneca has contributed to equitable access to the COVID-19 vaccine?
Thank you, Professor An, for an interesting question. First of all, I would like to say that it is a great honor to be here with such distinguished panelists and speakers. We are still fighting with COVID-19, and as Jerome Kim mentioned, the mutation of the virus has been evolving continuously, which makes the situation quite considerably worse. And as the audience here will recall that there was almost a war for securing COVID-19 vaccines, as many countries demanded early access to them. Mostly developed countries with large amount of capitals were successful in securing multiple and sufficient quantities of COVID-19 vaccines, and unfortunately the others will not. AstraZeneca actually had aimed to reduce such discrepancy early on to promote equitable access to the vaccine for global citizens, regardless of their wealth and social status. First, AstraZeneca has been supplying COVID-19 vaccine on a non-profit basis. It means that there is almost no discrimination for developing countries because developed and wealthy countries cannot pay a premium in order to secure COVID-19 vaccine early. Let me tell you why and how AstraZeneca came to such a decision. Back in 2020, when AstraZeneca was considering this COVID-19 vaccine opportunity, Oxford University, who has great relationship with us and really respect our corporate value of putting patient first, they suggested to work together and provide equitable access to the vaccine for the global citizens. We immediately reached an R&D and commercial agreement on non-profit principle. So our vaccine was co-developed with Oxford, and many of our clinical trials were funded by a number of governments, including that of the UK. So for us, because of this element of public funding, we believe that providing equitable access, or even ensuring the equitable access to at least AstraZeneca COVID-19 vaccine was the least thing to do. As a result, we were able to deliver more than 2.2 billion doses of vaccines to more than 170 countries in every continent. And 2/3 of that are actually consisting of developing countries. So that's the first thing we did. And second thing is AstraZeneca really closely work with local contract manufacturing organizations, CMOs, to expand global manufacturing capacity for ensuring equitable access to the vaccine. as you know, the demand for COVID-19 vaccine far exceeded supply. So most vaccine companies, including AstraZeneca, outsourced its manufacturing to a number of CMOs, including in selected countries. But one thing that really differentiated AstraZeneca from the market was that we did our best in providing the state-of-the-art technology, as well as regulatory support for each CMO. In South Korea's case, we partnered with a CMO called SK Bioscience, which was relatively new to the market back in 2020 and not a public company either. But we trusted its potential and decided to share our technology and made sure that the company could become adept at manufacturing the COVID-19 vaccine. And furthermore, we also advised and guided them through getting an EU GMP authorization. Now, the company, SK Bioscience, is an outstanding and also public vaccine manufacturing company, and they were able to deliver COVID-19 vaccines, not just to Korea, more than to 75 countries through the COVAX facility. So I really believe that it was a win-win for both companies, but also fostered the growth of biohealth industry in Korea. And as a result, Korea governments were able to secure locally manufactured AstraZeneca vaccine. It was the first COVID-19 vaccine supplied to Korea, effectively protected Korean citizens during the first crucial months. Finally, now that arguably we are entering into the endemic phase from the pandemic phase, and I think it will be, likely a long game in which real leadership will be more important than ever before. So AstraZeneca will continue to provide our COVID-19 vaccine at cost to low-income countries, and additionally provide antibody option for selected groups. Around 2% of the global population still remain vulnerable to COVID-19 because of an inadequate immune response to a COVID-19 vaccine. They are the target for this antibody option. It's a relatively small number if you think about it, compared to the rest of the 98% of the population. But as a company that puts patient lives first, we will continue to bring these kinds of important priorities of the world to the company and act with urgency. To close my speech, let me share a conversation that I had with a senior board director of AstraZeneca a couple of weeks ago. I asked him point blank why he had agreed to this non-profit principle, because it caused some turbulences, to be frank with you all. He said that he did not want to have to tell his grandchildren or even great-grandchildren that he had turned down this great opportunity to fight the COVID-19 pandemic because it did not make sense commercially or even in terms of profit. I think this is something we all need to really think about during this intense period of the pandemic. Thank you for listening, and let me wrap it up there.
Thank you. Well, even you explained the AstraZeneca's experience and decisions to fight the COVID-19, but your comment give us a kind of resonance from Dr. Jerome Kim's the concept and explanation to fight this disease. So not just giving or not just donating some amount of vaccine itself, but you also try to share your technology or to transfer your technology to the other countries. It's quite necessary component of our strategy. Thank you for your
Thank you.
comment. And Councillor Buttigieg, so given the UK's early rollout of vaccinations and the leadership of the G7 in 2021, could you explain UK's effort to enhance global access to vaccinations, how it sees the global context?
Sure.
Yeah.
So, first of all, good afternoon, ladies and gentlemen. Thank you very much for inviting me here on this excellent panel with some real expertise. It's a real pleasure, particularly thanks to Yonsei University and the Ban Ki-moon Center for Global Citizens. I've had the pleasure of meeting Mr. Ban Ki-moon several times since I've worked here in Seoul, normally to talk about climate change, but it's fantastic to also broaden that to work on the SDGs more generally. We're glad to support that. I brought a few slides today just to sort of put a bit of a human touch to what I'm about to talk about. Hopefully you can see them. But to start with, if you look at slide 1, this is a picture from Twitter that we put up in the British Embassy. It's actually a video from nearly 2 years ago in the British Embassy Seoul, so 27th of March 2020. What we're doing there is clapping for the NHS in the UK. It was a big phenomenon where the healthcare system was under a massive strain. Everybody had huge faith and sympathy for those working in it, and so we wanted to show them that we all supported them, and we were clapping. But that picture is us in the embassy thinking about this quite crucial point, because actually about that time you had in Korea the Daegu outbreak just coming under control.
Excuse me, just a moment. So can we have his slide? Okay?
Yeah? Sure. Thank you for sorting that out. So around that time, anyway, was the Daegu outbreak. So the center of the emerging pandemic here in Korea was on Daegu. Case numbers had just come down from 900-ish a day, which seemed huge at the time, down to about 100 or so. And in Korea, people were wondering, is this the end, actually? Is this it? We're obviously wrong on that, and there was a long way to go. But in the UK, we had, at the same time, we had this moment. So just a couple of days before that, we had our Prime Minister announcing our lockdown. So this was the first time we announced it. And, quite rightly, the focus of the headlines at the time were on medical services and shortage of supplies for our doctors and our hospitals. But one thing we are, looking back, very proud of is that even in that first speech, there's a line at the bottom there where the Prime Minister makes clear that he was asking for time. We needed the lockdown to provide time for our pioneering work on treatments and vaccines. And for the UK, that was always our long-term hope within this. And we wanted to really put that at the sort of middle of everything we were doing. So like a lot of countries, we threw our best minds and lots of money at the problem and managed to help to create a really important vaccine in record time. By December 2020, we had got to a point where we were rolling out the biggest vaccine program in British history. And we're now at a point where we've got about 2/3 of the British population covered by 3 jabs. So this is fantastic. And in South Korea, obviously, we have a situation where you've got huge triple jab coverage too. But as we're talking about, what about the rest of the world? And people have mentioned it here quite rightly. We're not in the same place around the rest of the world. This is publicly available data. It's just one graph of many you can find. You can break it down in lots of different ways. But what it shows is that lower middle income countries in particular clearly still are far behind what they need. They're not quite where they need to be. Why is this? Work on the SDGs, global health security, universal health coverage has been a focus of the world for years. We've known for a long time that we're only collectively as strong as the weakest link in our global health security chain. You only need to look at Omicron recently. Last summer in the UK, we thought we might have beaten Delta. We thought that might be it. And then Omicron came through the border, and it was all go again. There was talk of new lockdowns, etc. We're only protected if we all are. we know this, but we still haven't done enough to address this, globally speaking. And I'm sure academics are going to spend years studying why that is the case. But one thing is for sure, I asked our vaccine task force in the UK, you know, can you explain to me, can you show me a simple slide as to sort of why this is so complicated? And this is what they gave me. Just a very quick run through of some of the issues. And these issues are obviously much more complicated than this slide can possibly show. But the science, the clinical side, the supply chains, regulation, deployment, commercial, contracts, these things are incredibly complicated. And the final slide I'll show you is to sort of put some feel for that. Last year, I had the pleasure to help facilitate a UK-Korea mutual vaccine donation, so a vaccine swap, some people will call it. And you can see just from these little pictures how complicated it is for two developed countries to get this cold chain logistics system to work. It was incredibly complicated. It took me and my team and lots of very bright minds in both governments a long time to work on this. It was a great outcome, which meant that we both got the best out of what we needed. But how do you roll these things out to the world? How do you make that work? And it's great to have experts from the IVI and AstraZeneca and others on this panel to talk about that. But in the UK, we've certainly been doing our best to try and find ways to overcome this issue throughout the pandemic as we went along fighting it in our own country. We've really sort of, helped support COVAX, for example. That was a big part of our focus from the beginning. It's now delivered globally over 1 billion safe and effective vaccines to 144 participants. Our funding of about 600 million will help COVAX deliver through Gavi at least 1.8 billion doses to low and middle income countries by mid-2022. And we are committed to helping the likes of CEPI too. We have been since 2018 and we continue to do so. We've been championing dose sharing with 100 million doses over the next year. And we're big donators to Gavi to try and help get the vaccinations to the developing world into people's arms. These are bodies with significant expertise for overcoming these challenges, but we need to learn the lessons that we've got through this pandemic as to how we can think differently in future and make sure that we continue to do so. Importantly, that thinking differently was there baked in the UK from the start, as described by our AstraZeneca colleague. The UK worked with Oxford, AstraZeneca, right from the start, invested £88 million early on to try and create this rapidly deployed vaccine with global use in mind. So the idea was that you wouldn't need complicated cold chain logistics. You could get it out to people on a non-for-profit basis, and that's amazing. That's real different thinking. Thanks to that, we have 2.5 billion doses now used in 170 countries. But we still need to do a lot more, and we recognize this. If we are to achieve WHO's target of, WHO's target of vaccinating 70% of the world population by the middle of this year. So we've been using our convening power in the G7 in particular to try and do that, and we were happy during our presidency last year to see the G7 commit to 1 billion vaccine doses in June this year. And we keep making that case in the G7, the G20, WHO, and everywhere we can, because we strongly believe we need to learn these lessons for the long term. So the next step on our agenda to try and break the cycle of panic then neglect, really, is the Global Pandemic Preparedness Summit that we're going to hold in the UK in March. This continues our G7 work on equitable vaccine access, and things like the 100 Days mission to learn those lessons from this pandemic to try and make sure that we can get those vaccines for the future threat that we don't know about yet, for disease X. We can get those vaccines in place, ready to go within 100 days. That's the mission. We're also going to be focusing on funding CEPI for the future to continue their excellent work with COVAX, to bake in access to early stage R&D contracts, to support them to raise the 3.5 billion they need for the new 5-year strategy to develop vaccines for future pandemics. But more than that, we and our partners believe that the time to embed these lessons is now. We must embed them into the global architecture for the future so that we don't just go back to where we always are after a big threat. So we're calling for, with our partners, a new pandemic preparedness agreement globally. We're doing a lot of work on that. I'm doing a lot of work on that. The UK government's doing a lot of work on that, with career support and COVID fighting credentials too, and its huge vaccine production potential too. And we're hoping that for the long term, we can really bake in these lessons that we've learned all the way through this pandemic. But, you know, to conclude, we've paid quite a global, huge cost so far, and it's still going on for the lessons that we're learning. We need to make sure that's an investment for the future, for our children's future, and to actually really mean it this time, and to try and bake it into that global long-term approach. Thank you.
Thank you. So while we are dealing this difficult and tough, we can say enemy or the problem. So one of the critical problem or shortage is healthcare professional. So, I'd like to ask Professor Yeom. You are an infectious disease physician and have an interest in tropical disease and infectious disease prevention strategies through the clinician network. And I heard that you participated in several clinical trials when the vaccine was first introduced in Korea. So I'd like to ask you about the possibility of a network shared by many countries, not just in one country. In addition to, please share your thoughts on what areas of cooperation should be improved to strengthen the clinical capability of countries with a relatively slow development in research and education on infectious disease. Dr. Yeom, please.
Thank you. Good afternoon, everyone. Thank you for having me here today. So, I was involved in the developing clinician-based network in Korea, mostly by the infectious disease expert. Actually, we started to develop this clinical network after the outbreaks of MERS in 2015. And after making that network, actually in the meantime, people involved in this network usually shared some case-based unknown newly infectious diseases occurring in Korea. But after this COVID-19 pandemic started, actual value of this clinicians-based network started to work and develop in Korea. So since the first case and second and third cases started to occur in Korea, all of physicians involved in these caring COVID-19 patients started to share their experience, their knowledge, or their opinion in making policies for response to COVID-19 was starting to be going on in this clinician-based network. And since then, these clinician-based networks started to work really well during these 2 years of COVID-19 pandemic. So actually, this network started as a sharing platform for knowledge or experience in new infectious diseases. But since the COVID-19, now this network started to provide or making a lot of clinical data, clinical experience, and making this policy for coping with infectious diseases in Korea. And also this network, people involved in this network is starting to share their experience and involved in the new clinical trials of vaccines or new therapeutics related to COVID-19. And also, they are the ones who are in the front of the implementing these new vaccines and new therapeutics of COVID-19 in Korea. So those kind of informations are rapidly shared through the networks. And actually, those kind of experience really help in Korea of developing infectious disease policy and coping with this huge pandemic of COVID-19. So actually, we are trying to expand our network in Korea, not just by the infectious disease expert, but we are also trying to expand this network to the physicians who are interested in dealing with infectious disease at the community level. So hopefully, if our network can expand more nationwide, then probably this network, not just working as a knowledge and experience sharing platform, but also this network can work as a front runner in implementing new therapeutics and vaccines in the country. So actually this experience really helped us in overcoming this COVID-19 pandemic. So probably these kind of clinician-based network can be made in several other lower middle-income countries, and that network will be helpful not just for the dealing with the infectious disease in their country, but also the communication with the other countries as well. So in the early in the COVID-19 pandemic, our network started to communicate with the other countries who are in the early phase of COVID-19. So we had conversations with the other many national agencies like US CDC or other European countries, official organizations. So those kind of experience is one of the good case that this network can contribute to the control of infectious disease around the countries or globally. And probably if those kind of network can be made in a lot of countries, and then those network can be also expanded to the development of clinical trial networks, or maybe providing new platform for evaluating new therapeutics in the infectious diseases that whatever will be coming on in the future. So in the aspect of global development project that we are doing, especially in Korea, actually in the past days, most of the project has been focusing on developing like a hardware healthcare in the healthcare sectors, but actually in the infectious diseases sections, not just providing these hardware like building the hospital, or just providing some IT technologies for controlling infectious disease, but actually developing this clinician-based network in the country or in the community level can be a great asset in controlling the infectious disease, especially when there's new infectious disease coming on in the future. So hopefully our experience or our knowledge in running this clinician-based network can be shared to the other lower or middle-income countries. And if they adopt our experience, then probably those human clinical-based network built in the LMIC countries can be cooperated with us, and probably that will lead us to the more rapid or efficient responses to the newly infectious diseases coming on in the future. Thank you.
Thank you. I'd like to invite our very special panelist. He's Peter J. Hotez. In addition to his position of the Dean of the National School of Tropical Medicine at Baylor College of Medicine, also he's a co-director of Texas Children's Hospital Center for Vaccine Development. Dr. Hotez has developed a new patent-free COVID-19 vaccine called Corvivax that is designed specifically for global health. Dr. Hotez, you tremendous you've made tremendous contributions to global health development through research in tropical medicine, and you have been very vocal about vaccine inequity. So could you share with us how you have decided to waive the patent for the new vaccine and how Corbevax can be a game changer for global vaccine equity? In addition, it seems that the inclusion of researchers from developing countries could accelerate innovation in medical research and could support them to become the next leader in the field. So could you have any, do you have any thoughts or ideas on this?
Well, the reason we chose not to file a patent on this COVID-19 vaccines is we make vaccines for global health. And by we, I mean our Texas Children's Center for Vaccine Development. We make vaccines for poverty-related neglected diseases, for the poor, diseases such as schistosomiasis and Chagas disease and hookworm infection, which affects the poorest regions of Asia, Africa, and Latin America. But we also have a coronavirus program for the last 10 years. And we decided to do, for our vaccine for COVID-19, to make a low-cost recombinant protein vaccine made by microbial fermentation in yeast. And we chose this technology because this is a technology that's in place in many parts of the world, in Brazil, in Argentina, in Vietnam, in Taiwan, of course, and in Bangladesh, and Indonesia, and in India. And so the idea would be that this is a vaccine that we could transfer the technology with no patent, no strings attached. We actually help in the co-development, and then it could slot into their manufacturing capacity because our technology is quite similar to that used to make the recombinant hepatitis B vaccine. That's also done as microbial fermentation in yeast, so it could slot right in. And so we think this is the fastest way to advance a low-cost recombinant protein vaccine. And now the one that's furthest along is our colleagues in India with Biological E. This vaccine has now been released for emergency use. They've produced 250 million doses and hope they'll produce 1 billion doses. And so it's very exciting to be able to advance this vaccine for global health. We're also hoping that this gets done for Indonesia and Bangladesh and Southern Africa. So really trying to fill that global equity gap that's been so difficult. Another aspect of our Texas Children's Center for Vaccine Development is devoted to capacity building. And I took this very seriously when I served as U.S. science envoy in the Obama administration for the White House and State Department to build vaccine capacity in the Middle East and North Africa. And now we're trying to do this on a global scale. So in our laboratories, we invite scientists from all over the world to learn actually how to make a vaccine at scale under a quality umbrella, quality control, quality assurance, working with national regulatory authorities. And that's somewhat unique because not many academic labs, even labs that call themselves vaccine institutes, but most of them are really immunology institutes interested in vaccines. But here, our group is a hybrid between biotech and an academic setting, so we can actually teach people how to make vaccines. And that's very important because right now you cannot walk into, say, Moderna or Pfizer, say, show me how to make a vaccine. With us, you can.
Thank you. Well, even we don't have enough time, but as I'd like to hear your your answer or your opinion. So we gave you the common question. So what would be a couple of specific steps or solutions for the global vaccine equity? So Dr. Hotez already gave his reply. So Dr. Hotez, please.
A long way to go to achieve global vaccine equity. I think part of the problem is the fact that we're very dependent on the multinational pharma companies, and they occupy a lot of resources. And the multinational pharma companies do a lot of good and provide vaccines for the Gavi Alliance, even pre-pandemic. But the key is not to rely exclusively on the multinational companies. We need to diversify to include vaccine producers in low and middle income countries. They need our support, as well as academic nonprofit product development partnerships, such as our Texas Children's Center for Vaccine Development. Another example is the IVI, the International Vaccine Institute in South Korea. So I think what we need to do is really to build that capacity across the ecosystem, not only the multinational pharma companies, with an array of technologies, because for any new pandemic, you never know which technology will be the best. So for instance, for Ebola, the VSV technology, vesicular stomatitis virus technology, proved to be so critically important. mRNA has been important, but not only mRNA. So I think having in play hubs that can make vaccines using different technologies, a diversified array of technologies for VSV, mRNA, DNA vaccines, adenovirus vector vaccines, nanoparticle vaccines, and yes, even our sort of old school recombinant protein vaccines made by microbial fermentation in yeast. This represents the best hope, I think, to achieve vaccine equity.
Thank you. And Dr. Hotez invited IVI while he's giving his comment. And Dr. Jerome Kim, please.
Thanks, Professor An. Sorry. So I think the best way to think about this is to mind the gaps. Mm-hmm. So there was a vaccine supply gap, there's a diagnostics and sequencing gap, mm-hmm. and finally, and this is very important, there's a vaccination gap. I mean, mm-hmm. not so obvious in Korea, but in countries mm-hmm. and around the world, there are gaps in vaccination, and in particular, particularly in low middle income countries, there's an absorption capacity gap, which was highlighted by the Tony Blair Institute for Social Change in a white paper in August of last year, which really gets to some of the issues. A vaccine by itself won't do anything. It's vaccination that saves lives. And the capacity to do vaccination is going to be a critical part of our response in 2022. This is about leadership. What we have our countries, the G7, the G20, all of goodwill. Everyone wants to help. What we don't have is leadership. Mm-hmm. And what do I mean by that? It's the difference between an orchestra without a conductor and an orchestra with a conductor. We need an organization or a group of people who have the plan from end to end, mm-hmm. not only with manufacturer discovery of new vaccines and manufacturing of new vaccines and the implementation of vaccination programs, but there needs to be an end-to-end vision, and that is something that we, at this point still, mm-hmm. two years into the pandemic, desperately lack. We need a better version of COVAX, which is 50% short of its goal. It's a great idea. We had never before distributed 10 billion doses of innovative vaccine technology in the first year of use mm-hmm. in high-income countries and to some extent in low and middle-income countries, but we failed pretty significantly in low-income countries. We can partially address this also with regional manufacturing hubs, and both Professor Hotez and Mr. Buttigieg also mentioned support for regional manufacturing, and this is going to be a very critical part of a future fight against pandemics. We need to have advocacy for diagnostics and sequencing and building that capacity all over the world. We need to strengthen health systems so that we have fewer instances of absorption capacity problems, mm-hmm. Distributing vaccines for the next variant of COVID-19 or for the next pandemic, or for that matter, to turn vaccination from something we think of only for children to something that we think of as lifetime protection against infectious diseases.
Thank you. So just feel free, give your comment. So.
Sure, thank you. Actually, I'm very glad to follow DG Kim's points there, which I thoroughly agree with. I think what he's just set out quite nicely in his mind the gap point is that, and the rest of the point was that there's a lot now in place. Throughout the last couple of years, we've learned to put in place some really great tools. If we think about the access to COVID tools, accelerator work, there's some really great tools, but there are still some gaps but we've actually got quite a good idea of where those gaps are and how to fix a lot of those gaps in principle and in theory. What we now need is leadership to actually make that work, and I think that's exactly where we're coming from. We started that. We tried to start that leadership through the G7 into the G20, and we now really think that we need this global, permanent pandemic preparedness architecture to try and bake some of this stuff into future pandemics, epidemics, that we don't know about yet. We don't want to be in a position where we just have to go back to square one and set all these things up again. We know where these gaps are, we know how to work on them, but again, getting the international community to work on those things is a challenge. It's a challenge that I certainly wrestle with, and so does a massive number of government colleagues and businesses elsewhere. But throughout it all, we need to think differently. Businesses need to think differently, governments need to think differently. We've seen that happen, and we can do it again in the future. I think if we manage to come together through this new sort of architecture and put some of this stuff in place permanently, we can be much, much better prepared for the future, but lots of work to do.
Yeah, right. Thank you. Dr. Do, please.
Okay, I think, the panelists already made a great point. One additional point I would like to make is that I think information is quite critical. Correct information, delivery of the information is very important for policymakers, as well as public health, as well as pharmaceutical companies. Infectious disease medical institutions will continue to generate real-world evidence, and that will really affect what kind of vaccines each country has to use according to their genetics or even the environmental factors. So I think allocation, of course, in terms of equity, requires a lot of principles and leadership, but delivering and generating extra information and data would be quite critical in the coming days and months.
Thank you. And
yes, I certainly agree with all of the points that made by the Professor Jerome Kim. And since I'm a clinician or taking care of COVID-19 patients and providing vaccines, actually I think that in my talks I already mentioned, but there are many things that we have to consider in implementing the provided vaccines in the country and also in the community levels. And of course, we need a very strong healthcare system in every country to implement effectively all the vaccines or therapeutics provided in their countries. But I think there's a big role for this clinician-based network to work in the aspect of providing those vaccines or therapeutics effectively in those countries. So not just the providing vaccines, but also organizing those human networks in these countries can be also a big important point in overcoming this COVID-19 or newly coming infectious disease in the future. Thank you.
thank you. Thank you for your participation and for giving us your insights on this important issue. Although we are still facing the staggering rise of the COVID-19 pandemic, and still have a long way to go, I believe and I hope we humankind will eventually overcome this disease. While we were going through the valley of the pandemic, we have learned the crucial roles of vaccines to deal with the infectious disease. We realized the need for a more efficient and safer way to develop effective vaccines, and need for equitable distribution and efficient administration of vaccines. And what I learned from here today, the attitude to mind the gaps, and the leaders who lead or the newer, better systems to fight or to deal with these complicated issues. So this need only can be solved by the collaboration of government, academic institute, international organizations, and business partners, including pharmaceutical companies. Once again, thank you for your endeavors and opinions and for your participation. Thank you.
Thank you, Professor An and the panelists. In Korea, we were so focused on securing vaccines, but through this session, we were able to know that there were a number of efforts to leave no one behind in terms of access to vaccines, which we had also discussed with UNHCR's Special Envoy, Angelina Jolie, last year. So may this year be comprised of days during which we make concrete actions for equitable vaccine access. So now we will take another break and resume at 3 p.m. Korean time. Thank you.